Hello and welcome to this new module about zoonoses and rabies. It is said that sometimes good things can even lead to hazardous outcomes like rabies. So we are going to talk about a lovely doggy-related program, rabies, and the National Rabies Control Program, beta. The competencies which are related to this video module, we need to talk a little bit about zoonotic disease, talk about the response and influence of the host systems, and prevention of rabies, which is a very 3 by 5-star MCQ topic for your exam. So let's have a few words about what are the different types of zoonoses. Zoonotic disease is any disease which is occurring from the animals to humans, right? So the zoonotic diseases can broadly be classified into 4 types. We can have the cyclozoonosis, metazoonosis, the direct zoonosis, or the saprozoonosis. What do you mean by a direct zoonosis? Very simple to understand. Direct zoonosis is that there is a vertebrate animal, right? Vertebrate animal or the source of any organism, and this goes directly to the human or the vertebrate host, right? So from the vertebrate to the vertebrate direct it goes. There is no change in shape, or there is no change in development stage, or replication or the multiplication does not happen in between them. Typical example for a direct type of zoonosis is rabies. Or we can also have brucellosis or rabies directly from a vertebrate to another human. So that is what is direct zoonosis, from a vertebrate to a vertebrate. Example we have talked is rabies. Please note this may involve direct contact, it may involve fomites or whatever. What do you mean by the cyclozoonosis? Cyclozoonosis means that there is some cyclical change and the agent is roaming around in cycles. That means there is a vertebrate host, there is a vertebrate source, and then it goes to another vertebrate, and then only it can come to the host or to the human, right? So now it needs another vertebrate. So when the infectious agent will require 2 or more vertebrate host for development or multiplication, this is called as a cyclozoonosis. So let's write it down. Cyclozoonosis, there will be a vertebrate host, there will be another vertebrate source, another vertebrate source, and then it reaches the human. It could involve many vertebrate sources. Example, I think we all know, for example, Taeniasis, where we can have the cattle or we need a pig. So different types of vertebrate hosts will be there, sources will be there. Next, another example that we can note is Echinococcus. Example for this, like the vertebrate sources could be the dog. It also needs another intermediate host, that is the sheep. So different types of animals will be involved before it reaches the human. That is a cyclozoonosis. What do you mean by a metazoonosis? Meta means something which is different. So meta means now the organism will be there in an animal source, that is a vertebrate source. It will also be there in invertebrate. That is what is meta. Just remember what is meta. So in meta, there is a vertebrate source of infection, or there could be a reservoir of infection, and this vertebrate will require a invertebrate organism, that is what we call as vector. This could be like fly, like ticks, like mites, so many things are there, and then only it is applicable to infect a human or a host or a vertebrate host. This is what is called as metazoonosis. In this, please note that in the vector there may be propagation. What do you mean by propagation? When we talked in entomology, I think we had discussed there. We also discussed it in the separate module in infectious disease epidemiology. What do you mean by propagation? Propagation means increase in the number. Or there may be a cyclical change, that is what we call as cyclodevelopmental increase. Or there may be both, that is a cyclopropagative transmission. So the transmission could be a propagative cyclodevelopmental or a cyclopropagative. What is cyclodevelopmental? Where there is change in shape, right? And what is cyclopropagative? That is both. There is both change in shape and change in number. So when the infection comes from any animal source to any insect source and then it comes to host, that is called as metazoonosis. So let's write it down. What is metazoonosis? From the animal sources, it will go to the insect sources, that is the invertebrate, and then it will infect the humans or the vertebrate host. है ना? That is what. So in the insect, it can have different types of biological transmission. I don't need to give you example for this. Example for this could be hundreds of example. Example could be arboviral diseases. We can have plague. You remember plague from the rat to the rat flea and then to humans. Or we can have schistosomiasis. Schistosomiasis. So different examples could be there for metazoonosis. We have many infections which are metazoonotic infections. Next is saprozoonosis. What do you mean by saprozoonosis? What is sapro? Saprozoonosis. Sapro means anything which is apart from a different species. So not only animal kingdom, we may talk of different kingdoms. So in this, very simple to understand, if there is a vertebrate source or animal source in simple language, then they involve a non-animal source. Non-animal source, that is what you change the species. So from animal source to a non-animal source, and then it comes to then it is eligible to infect the humans, or you can call it as a vertebrate host. This type of infection is called as saprozoonosis in the non-animal host. What do we mean by this? Like non-animal, it could be anything. It could be any non-living substance or material. It could be any non-living reservoir. It could also involve the plants. Plants are of course non-animal thing, right? So it could also involve the plants. It could involve soil. So if infections like these are called as saprozoonotic infection. Very common example that we may relate is that about the mycosis. Many mycoses are actually saprozoonotic infection. Then you have larva migrants. These are all examples of saprozoonotic infection. So saprozoonotic is from the animal to a non-animal area and then to the humans. Example is mycosis, or we can talk about the larva migrants. Having understood about the zoonotic disease, let us move over to understanding of the rabies. Rabies is a direct zoonotic disease. Just now we talked. It is a direct zoonotic disease. It is one disease which we know is 100% fatal. It is one disease for which there is no cure. If it happens, unfortunately, we lose the person. So as always, for rabies, we are going to talk about the agent factors, the host factors, and the environmental factors. Environmental factors do not carry any public health importance in rabies because rabies can occur at any time of the season. There's no air, water related to it. But yes, there are some agent and the host factors which you should be knowing. The agent factors, as far as the agent factors are concerned, it is a Lyssa virus 1 from the Rhabdoviridae family. Please note that the agent of this rabies, that is the rabies virus, it's a viral disease, right? Rabies virus is of two types. We can have a fixed virus or we can have a street virus. What do you mean by a fixed virus? Fixed means it has a fixed what? It has a fixed incubation period. So what is the incubation period of the fixed virus? The fixed virus incubation period is roughly ranging from 5 to 7 days. If you get a simple answer, single average answer, the best answer would be 6 days. So it has an incubation period of 5 to 7 days. What is the incubation period of a street type of virus? The incubation period is variable incubation period. It could be as low as 7 to 10 days to as high as some months or years. So there is no funda of incubation period in rabies. The street virus is the virus which we all are scared of, and this street virus may cause the disease of rabies. Whereas the fixed virus, it does not cause the disease. Please note that a lot of times you get MCQ on this, that the fixed virus, it will not have Negri bodies production. It does not cause a disease, and the fixed virus is used in production of the vaccines. It is used in the production of vaccines. So it is the fixed virus which is used in the vaccines, whereas it is the street virus which is the organism which is implicated in causing the disease. Next is, if we talk about the host factors, it has some age predilection. Of course, there is no age which is immune to rabies, but it has been seen that the peak age of rabies is 1 to 24 years in a very young adults, which is of course unfortunate event because rabies is 100% fatal, and it is also seen to peak with some occupations, which is common sense, I think, in the veterinary doctors, in the people who are hunters, in people who are working in forest areas and so on, who are dog handlers and all these. So there are some high risk occupation, and the age predilection is 1 to 24 years. Next is topic number 2. What about the animal bites? What about the animal bites? Please note that in India, in a country like India, it has been shown that bats related bites or bat bites do not carry the rabies virus, and they are not the major mode of transmission of rabies in India. Similarly, the rodents, they do not cause rabies in India. So please note that if you talk in a separate module, if you talk in a practical situation, a person is sleeping and the person gets a rodent bite on the feet. So now if that person gets a rodent bite on the feet, the person will not know whether it was a rodent or a monkey or a wild animal or whatever it was, some nibbling was there. So whenever in doubt, we always give rabies vaccine because rabies is 100% fatal. Always give rabies vaccine. But if the MCQ wala specifically ask you that there was a documented rodent bite or a bat related bite, answer is we do not need to give the rabies vaccination. In India, major public health problem is with dog bites, cat bites, monkey bites, all the wild animal bites, they all will be major source of rabies in India. Topic number 3 is what is the animal bite classification. Beta, as the animal bites, we have 3 classes, class 1, class 2 and class 3 animal bite. In the class 1 animal bite, we will take into account only licks and touch to the animal. In class 2 bites, there are minor abrasions or lacerations. Please note that the licks and the touch will always be on intact skin. That is important. On intact skin, if there is a lick or a touch, that is class 1 bite. However, if there are minor abrasions or lacerations, that is class 2. That is the skin integrity is broken. So now only the skin integrity is broken, that is a class 2 bite. In class 3, there is a blood integrity broken, that means there is oozing of the blood. If there is blood oozing, if there is a touch or a lick, not a touch, in fact a lick on the mucosal surface. So licks on mucosa is categorized as a class 3 bite, and blood and deep tissue injury, common sense, in deep tissue injury, it will all be classified as class 3 animal bites. So what are we going to do to these? Please note that in class 1 animal bite, nothing has to be done. Of course, very important, the wound management has to be done in case if there is a wound management. In class 2 bites, we only give the anti-rabies vaccine. And in class 3, we always give the anti-rabies vaccine plus the rabies immunoglobulin. RIG stands for rabies immunoglobulin, and ARV stands for anti-rabies vaccine. So we always will give the RIG or we will give the ARV depending on whether it is a class 1 bite, class 2 bite or the class 3. Please note that all the wild animal bites, they are, if the bite is there, they are all classified into the class 3 bites. Management. Beta, whenever there is some wound, it should be taken care using physical methods. There should be a chemical methods, or there should be a biological methods, right? Very simple. The physical methods include of wound management include washing with ample soap, that is lot of soap, plus a running water, continuous running water. So you don't want to take a stagnant water or some polluted water. You want to take running water, because rabies, but then the person might get secondary infection, right? So we would take ample soap and running water, and we wash it for, that is MCQ, we wash it for minimum 15 to 20 minutes. If you get single best answer, please mark 15 minutes is the minimum time. So once we have done ample soap and water and washing for 15 minutes, now we can go with the chemical wound management. The chemical wound management may be using any alcohol-based antiseptics, or we can use povidone iodine, which is again a good antiseptic for wound management. Lastly, we can go with the biological method of wound management, that is we can use the rabies immunoglobulin. That is the biological method. Whenever there is wound, so it is always recommended that the wound, that means the deep tissue injury is there, it is always recommended to irrigate wound with the rabies immunoglobulin. Whenever there is a deep tissue injury, in case of deep injury, any animal bite with a deep injury due to wild animal or whatever animal, so any deep injury, it is always advised, what about the sutures? In case the suturing is required, it is advised to do it after 24 hours. There should be a delayed suturing. And this suturing should be loose sutures. Of course, common sense. Why? Because we want to avoid any injury to the nerves over there. So delayed suturing, it should be a loose suturing or a minimum suturing. Minimum intervention should be there in case of wild animal bites. Alongside the rabies immunoglobulin, the person who got the wound may also need the tetanus toxoid vaccines, or the anti-rabies vaccine, or the rabies immunoglobulin as per the animal bite classifications, whether it is class 1, class 2 or class 3. So now, having said about the wound management, let us have a word about the anti-rabies vaccine. If we talk about the anti-rabies vaccine, first MCQ. What is the type of anti-rabies vaccine that we are using? Please note, we are using a cell culture vaccine. Out of these cell culture vaccine, which vaccine has the best response? It is the HDCV, that is the human diploid cell culture vaccine. I would like to tell you that the neural tissue vaccines, they are obsolete now. We have phased out the neural tissue vaccine. Everywhere we are using the cell culture vaccine. Different companies are available. Virorab, Rabipur, Vaxirab, Abherab. So many rabies vaccine will be available, and all are cell culture vaccine. However, HDCV has the best immune response. HDCV will have the best immune response. Next, a point over here, frequently asked MCQ is that the anti-rabies vaccine, what should be the minimum standard dosage? Please note that the dosage, I'm not saying that how much to be given as intramuscular or intradermal, the dosage in that particular vial should be more than 2.5 international units per IM injection. For every IM injection, for how much you insert in IM, whatever amount you insert, it should have that 2.5 international units of the rabies vaccine, of the inactivated rabies vaccine. It should be more than 2.5 international units per IM injection. Another point over here for you, we are still on the anti-rabies vaccine. Another point over here that I would like to mention is that what is the dosage? This is the general understanding we are doing about the anti-rabies vaccine. You should know that what is the dosage that we give now. So dosage or administration, how much dose to be administered, given to that patient. The dosage that we give is, in case I will be talking about the intramuscular injection. In intramuscular injection, it is the complete vial. Different companies are there in India. So some company will be making 0.5 ml vial. Some will make 1 ml, some will make 2 ml. So whatever ml vial is there, you have to completely give that vial in case of intramuscular injection and in case of intradermal injection.
Okay, there's a very 5-star MCQ topic. A lot of times it has been asked. In case of intradermal injection, the dose is fixed. It is 0.1 ml. Okay. Another point which relates over here is that how about this vaccine? How is this vaccine? This vaccine will all contain inactivated rabies virus, and this vaccine, all the rabies, anti-rabies vaccine, this vaccine bache is a freeze dried vaccine. So if it is a freeze dried vaccine, of course you cannot put powder, so that means it should be diluted with something. So if it is diluted, the diluent is given along with the rabies vaccine. So the dilution is there. So it is diluted and then injected. It is always diluted then injected. If you understand this, now you'll be able to relate what I'm going to say next. That point number 5, what is the shelf life of the vaccine? Please note that the shelf life is 1 to 3 years. It has to be maintained at 2 to 8 degrees Celsius. If it is maintained at 2 to 8 degrees Celsius, the shelf life depends on different manufacturers. It could be 1 to 3 years. But in case we are reconstituting, if you are reconstituting, that means you are adding the diluent. The reconstituted rabies virus vaccine should be used within how much time? Within, remember the open vial policy? Within 6 hours. The reconstituted vaccine cannot stay for 1 year, 2 year, 1 month, not even 1 day. It will have to be used within 6 hours. So what is the dose we give? 0.1 ml in case of intradermal. In case of intramuscular, the complete vial. The diluent is always given. You have to dilute it and use it within 6 hours of giving the anti-rabies vaccine. Next, another last point for us to do is point number 6. That in case of giving anti-rabies vaccine, what are the regimes that I'm going to discuss? Right now, I'm just putting the basic things in your brain somewhere. So the regimes beta that we use, we can have a pre-exposure prophylaxis, or we can have a post-exposure prophylaxis, or we can have a re-exposure prophylaxis. Okay, what do you mean by pre-exposures? That means the dog bite not happen. You give the vaccine prophylactically before only. So this is given before dog bite. Post-exposure, dog bite happen, you give the vaccine. Post-exposure, re-exposure, the dog bite happen, you take the vaccine, again that stupid dog bites you again. That is a re-exposure prophylaxis. So please note that in all these cases, you are doing prophylaxis. Can you think and tell me what is this level of prevention? Pre-exposure prophylaxis, this one. So pre-exposure prophylaxis, what level of prevention? Now try to understand, this patient has not had a dog bite. You are giving the vaccine before the dog bite to prevent the rabies. What level of prevention? Primordial prevention, primary prevention, secondary prevention, tertiary prevention. What do you want to say? It is a primary prevention. Do not answer primordial. Why? Because that patient is trying to take a vaccine. Why? To prevent a disease called as rabies. And why is he taking the vaccine? Because he's at risk. You did not take a rabies vaccine like pre-exposure. I did not take a rabies vaccine pre-exposure. So we will take a pre-exposure when there is a risk factor. This is a primary level of prevention. What do you mean by the post-exposure prophylaxis? Post-exposure. Now that person already has a dog bite. Now this fellow is taking the vaccine. So this fellow is taking a vaccine. Why? Again, to prevent a disease called as rabies. So what level of prevention? It is a primordial, primary, secondary or tertiary. Do not answer secondary level. It is not a secondary level. This person is trying to take a vaccine again to prevent a disease called as rabies. He's taking it because he is at a bigger risk factor. So post-exposure prophylaxis is also a primary level of prevention. It's a more important primary level of prevention. What do you mean by re-exposure? That person got the vaccine, got the animal bite, took the vaccine, again that animal bite. Now what do you want to say? This again and again, same answer. It is a primary level of prevention. So whatever the MCQ may say, do not get confused. We are talking about prophylaxis. Prophylaxis means to prevent a disease. So there is no understanding, there's no need of understanding over here. Every type of prophylaxis, chemo prophylaxis, vaccine prophylaxis, they all are primary level. We already discussed about this in the chapter on screening of disease, where we talked about prophylaxis and the levels of prevention.
So now let us move forward and talk about the regimes or the National Rabies Control Program 2019 updated guidelines. So whatever I'm going to discuss over here is from the NRCP, that is the National Rabies Control Program, NRCP 2019 guidelines for us. So beta, in this we need to understand different types of regimes, right? Let us first focus on a regime called as a pre-exposure prophylaxis. Pre-exposure prophylaxis. Pre-exposure prophylaxis means before the dog bite. So what does the guidelines say? The guidelines say that the person should be taking 3 doses of the vaccine. 3 doses of the vaccine should be taken. It could be both. It could be intradermal, it could be intramuscular, whatever type. Intradermal 0.1 ml, intramuscular is complete vial. This 3 doses is to be taken on day 0. It is to be taken on day 7 and day 21 or 28, whatever that person will feel like. So in 1 week, you ask the person you come on Monday, then you ask the person to come on next Monday, then you ask the person to come on next, like the 4th Monday. So this is taken on 0, day 7 and day 28 or day 21, whatever the person will feel like. So how many doses we are giving, beta? In this, we are giving 3 doses. How many visits, for how many days the person is coming? 3 visits and 3 doses. You can give this intramuscular or intradermal. That was your pre-exposure prophylaxis. So the next one is, let us talk about the post-exposure prophylaxis. The post-exposure prophylaxis could be different now. Beta, the post-exposure prophylaxis, now the person is going to take the vaccine only after the animal bite. So once the animal bite has happened, the person has 2 options. Either they can go with a SN schedule, or they can go with a modified Thai Red Cross schedule. The SN schedule MCQ is intramuscular. The Thai Red Cross schedule is intradermal. The SN schedule is intramuscular and Thai Red Cross schedule is intradermal. If I just show you the SN and the Thai Red Cross schedule, can you see over here? This one, the top one is the SN schedule. In SN schedule, it is all our intramuscular injection. Where do we give intramuscular injection? Please note, it's always in the deltoids. It is never means never in gluteal. Never in the gluteal region. In case of children age less than 2 years, because their fat is very less in the deltoids. So in children, we may use the anterolateral thigh. Anterolateral thigh may be used even up till 5 years or 7 years whenever the child is okay with that. But in gluteus, we never use because the fat content is very high and the vaccine efficacy is not observed. So please note that in the intramuscular regime, that is the SN regime, there will be 5 visits. Next MCQ, how many visits you can see? There are 5 visits. When will the patient make the visit? Day 0, day 3, day 7, day 14 and day 28. So how many visits we see? We see 5 visits, 1, 2, 3, 4 and 5. So SN schedule is with 5 visits. In each visit, you give 1 intramuscular injection in any arm. So you give 1 dose of intramuscular. What is the dose of intramuscular? It is the complete vial. This is what we call as the SN regime. Next in line, let us talk about the Thai Red Cross regime. If you talk about the Thai Red Cross regime, in the Thai Red Cross regime, now the visits will change because Thai Red Cross regime is purely intradermal. Now the visits are going to change. You will give on day 0, day 3, day 7 and the 14th day is skipped off. Okay, 14th day is skipped off and now you will give it on day 28. So how many visits do we see? We see 4 visits. We see 4 visits in the Thai Red Cross schedule. And in the Thai Red Cross schedule, in each visit, how many intradermal injections are we going to give? Intradermal, what is the dose? It is 0.1 ml. So we are going to give 2 intradermal injections, that is on 2 sites. It is given on 2 sites, 2 sites, 2 sites and on 2 sites. So how many doses will be used? there will be 4 visits and 8 doses. Why 8 doses? Because 2 doses on every day. It is 0.1 ml this side, 0.1 ml this side. It's not 0.05 and 0.05. Total dose is not 0.1, it is 0.1 and 0.1. So total we are going to give 0.2 ml of the dose in the Thai Red Cross schedule. So let us have a quick writing over here. In the SN schedule, beta, how many doses you were giving? You were giving 5 doses. How many visits we had? We had 5 visits. Day 0, 3, 7 and 14 also with 28. In the modified Thai Red Cross schedule, we were having 4 doses. We were having 8 doses, 4 visits. 8 doses, 4 visits on day 0, day 3, day 7 and then day 28. Please note it is intradermal and it is given 2 intradermal injections on every visit. Are we okay with this? Now, having understood about the pre-exposure and the post-exposure, let us have a word about the re-exposure guidelines now. Beta, in the re-exposure guidelines, that means the person already had a dog bite and the person already was exposed to the vaccine. So what does re-exposure guideline mean? Third point, re-exposure guideline. Re-exposure does not mean about the animal bites. The person could have taken animal bite like 5 times. And let us say all the 5 times the person did not take a vaccine. So fortunately, he's still okay and keeping cool. So the re-exposure means that the person is exposed to the vaccine. So in all previously vaccinated, rabies vaccinated, right? Not about the measles, rabies vaccinated individuals, we will give the re-exposure prophylaxis. Now, what is the regime? What is the system? What is the regime that you follow? In re-exposure prophylaxis, we are giving only 2 doses. Only doses number 2. So, how many doses? 2 doses. So, that means you are giving on 2 visits. These are given on 2 visits. The number of visits will be 2. It is given on day 0 and on day 3, just 2 visits. And it is given as intramuscular or it can be given as intradermal dose, whatever we want to give. It could be intramuscular or it could be intradermal. It is given on day 0 and on day 3, 2 doses, 2 visits. Are we okay with this? This is a re-exposure regime, but there is a complication now. There is a problem now. Problem examiner will ask you that in what patients are you going to give the re-exposure. Please note, let's have a word upon this. This is a big source of doubt. It is a 3 by 5 star MCQ topic for your exam about the re-exposure prophylaxis. Who's the eligible population? Eligibility criteria for a re-exposure prophylaxis. Beta, please note that the re-exposure prophylaxis will be given to whom? To the person who had taken the vaccine. That person could have taken a pre-exposure prophylaxis or the person could have taken a post-exposure prophylaxis. Then we are going to give the re-exposure. So in case of that person had taken a pre-exposure prophylaxis or the person could have taken the post-exposure prophylaxis. The post-exposure prophylaxis, you understood, you already know that it is of how many regimes, the SN regime and the Thai regime. So this person already had taken either 4 visits or had taken 8 visits, 5 visits. So let's write down about the doses. The person could have taken 5 doses or the 8 doses of intradermal or 5 doses of intramuscular. In case of post-exposure, in case of pre-exposure, the person already had taken only 3 doses. Could be intramuscular or intradermal. Now the point for you to understand is rabies is a 100% fatal disease. So in all cases, bache, please note, in all cases of people who had taken a documented, it should be documented pre-exposure prophylaxis, whether within 3 months, more than 3 months, just 1 week before, whenever. So all cases of pre-exposure, anytime, there is no cooling period. So let us say that the person had taken a pre-exposure prophylaxis on day 0, day 7 and day 28. So he was very happy on day 28. Day 29, he was going home and the dog bite him. And the rabies dog bite him. So that is so unfortunate. Will he take a re-exposure prophylaxis? Answer is yes, because all cases, anytime they need a re-exposure. Why? Because they took only less dose. In people who had taken a complete post-exposure prophylaxis, now the research says that in case the person has taken a good amount of vaccine dosage, the body antibody level may be reasonably high. So the vaccine neutralizing antibody, which is there in the body, that could be reasonably high. So now we have a cooling period. So do not get confused. All cases of pre-exposure will get re-exposure, and people who are more than 3 months, they will take the re-exposure prophylaxis. And people who are within 3 months, you can give the cooling period, do only wound management. You do their wound management, and to be on very safe side, you can check their vaccine neutralizing antibody levels. If they are sufficiently more than 0.5, that is good. If not, you give the vaccine. But the guidelines say the cooling period of less than 3 months or more than 3 months only in case of the post-exposure prophylaxis. And last point, another point in the re-exposure prophylaxis is that there is no requirement of rabies immunoglobulin in case of re-exposed people. So people who had already taken either the pre-exposure or the post-exposure, the rabies immunoglobulin is not recommended. It could be within 3 months, more than 3 months, whatever it is, class 1 bite, 2 bite, 3 bite. Of course, in class 1, you're not talking about anything. So in class 2 or class 3, the rabies immunoglobulin need not to be repeated. There is no requirement of rabies immunoglobulin in the re-exposure categories. It's not repeated. That's all. Right? So now just to summarize whatever you had done, beta. You talked about the re-exposure prophylaxis. You talked about the re-exposure prophylaxis. How many visits did that person do? The person in re-exposure was on day 0 and day 3. That is 2 visits. In case of pre-exposure prophylaxis, how many visits did that patient do? 3 visits. That is on day 0, day 3, and pre-exposure was day 0, day 7, and 21 or 28. That is the pre-exposure prophylaxis. Then came the Thai Red Cross schedule. In Thai Red Cross schedule, how many visits were there? There were 4 visits. 4 visits, day 0, day 3, day 7, and day 28. That was the Thai Red Cross schedule. So on each day, there were into 2 doses. That means total there were 8 doses. Are we correct? And last, you learned about the SN regime. In SN regime, how many visits were there? There were 5 visits. That is day 0, day 3, day 7, day 14, and day 28. Are we okay with this? So now this is what you need to remember for your exam. Re-exposure you give to all cases of pre-exposure, but in post-exposure, people who had already taken a post-exposure, only more than 3 months. I would also like to tell you that how many alphabets you see in re. In re, wonderfully, I see 2 alphabets. So how many visits? 2 visits. In pre, I see 3 visits. In Thai, Thai, I see 4 alphabets. In SN, I see 5 alphabets. So actually, you don't need any brainer over here. The number of visits is the number of alphabets in these regimes. So this is just the direct summary guidelines from the National Rabies Control Program 2019 guidelines. This direct screenshot, we have already discussed most of the questions based on these post-exposure, pre-exposure, and the re-exposure guidelines. And now, after understanding about the pre-exposure, post-exposure, and the re-exposure guidelines, let us go to the next topic, that is the rabies immunoglobulin. The rabies immunoglobulin is kind of a little bit expensive, so the cost effectivity on a public health basis is a point of concern. So the irrational use or irrational use of immunoglobulin has to be justified. Of course, we are talking of a 100% fatal disease. The rabies immunoglobulin for your MCQs bache is of 2 types. We can have equine rabies immunoglobulin, that is ERIG. That is from the equine, that is from the horse, or we can have the human rabies immunoglobulin, that is the HRIG. The equine rabies immunoglobulin is given at the dose of 40 international units per kilogram, and the human is given at the rate of 20 international units per kilogram. The human rabies immunoglobulin, common sense, will have less side effects and it has better immunity. It has better efficacy and better immunity and better protection with a lesser side effects. The equine rabies immunoglobulin will be kind of having more side effects, and of course it's a little cheaper than the human rabies immunoglobulin. It's always advised to use a human rabies immunoglobulin. Now there are certain considerations regarding the rabies immunoglobulin. Rabies immunoglobulin is given only in case of all class 3 animal bites. You remember in the start only we discussed that all the class 3 animal bites, they will receive the rabies immunoglobulin, but also rabies immunoglobulin is given in case of immunocompromised or HIV cases or immunocompromised cases. In those cases, we give to all class 2 and class 3 bites. All class 2 and class 3 bites will get the rabies immunoglobulin. So that means RIG is given to all class 3 and class 2 bites in case of the person was immunocompromised. That is one point. Second, another consideration about rabies immunoglobulin that you would like to remember is that how to give the rabies immunoglobulin. Earlier, it was said that 50% give it in the wound and 50% give it in the muscle. Now, the recommendation says that it's not required to give it in the muscle. It's an immunoglobulin. You infiltrate in the wound whatever we can. So, majority or the maximum whatever is possible should be infiltrated in or around the wound, because that is from where the rabies vaccine, the rabies virus, in case the bite is here, so the virus will go up to the CNS. So there is a centripetal and then there is a centrifugal spread. It goes back to the different organs and the tissues. So the rabies immunoglobulin, it should be infiltrated in or around the wound maximum. Of course, caution has to be taken not to lead to a compartment syndrome. You don't want to infuse so much amount of rabies immunoglobulin that you actually cut off the blood supply. So you don't want to cause a compartment syndrome. Take a caution of that, but maximum should be infiltrated in or around the wound. And very important, whatever is remaining, you don't throw it off, remaining to be given at intramuscular site nearest to wound, near to the wound site. So wherever the wound site is, to that, the nearest intramuscular site, whatever is remaining, you infuse there. But maximum should be infiltrated in or around the wound. That is about the rabies immunoglobulin. And of course, we already had a word that rabies immunoglobulin is not repeated in the re-exposure prophylaxis. Next in line, another topic I would like to do is about the rabies vaccine in different situations. We already just now talked about the first situation, that is about the immunocompromised. In immunocompromised people or the HIV people or the transplant recipients or wherever long-term steroids are given, in all cases where the immunity is compromised, in them there are two important guidelines for us. That first, that instead of intradermal, the intramuscular should always be preferred instead of intradermal. In fact, intradermal is avoided in cases of intramuscular. We feel that it has better efficacy. That is the intramuscular. Second point is, in all cases of immunocompromised, the rabies immunoglobulin will be given to both class 2 bites and the class 3 bites. That was regarding the immunocompromised. Next in line is, what about the rabies vaccine in case of COVID? So in case the patient already had COVID, either the vaccine or the patient already had a COVID disease. So let us say that the person had taken Covishield today and after 2 days the dog bites him. Do we take a rabies vaccine? Answer is definitely yes. The rabies vaccine is given on priority. It is always given on priority, and when people who had taken a COVID vaccine, it is always advised that they take a rabies they always take a intramuscular injection rather than a intradermal injection. Point number three. In case of pregnancy, will the female take a rabies vaccine? Answer is definitely yes. The rabies vaccine is always given. Rabies vaccine is given. Even to a mother who is pregnant. We do understand that in females who took this rabies vaccine, there are high chances of miscarriage or abortions or the fetal loss. But all said and done, you're talking of 100% fatal disease. So in pregnancy, the rabies vaccine is definitely given. There is no doubt you're not going to give. Point number 4. What if the patient was having malaria? So that's such a bad thing that the patient already got malaria, and why would he roam around? But anyways, he was roaming and he got an animal bite. What does the guideline say? So in patients who already have malaria and on treatment, on treatment, on malaria treatment. Either they are taking the artemisinin based combination therapy, or they are taking chloroquine, or they are taking the primaquine. So whatever it is, in patients who are taking malaria treatment, it is always advised to give intramuscular rather than the intradermal dose. That's the only difference. So in malaria, we give intramuscular. In case of HIV, we give intramuscular. In case of COVID, we give intramuscular. So these are some areas where the rabies vaccine needs kind of a little bit more change in the regime. So which is the intramuscular regime we already talked? We already talked about the SN regime. SN regime has a better effectivity than the thyroid cross. If a patient does not have any risk factor, they can go with the thyroid cross. But if there is any risk factor, better to go with the intramuscular regime. It is known to have kind of a better immune protection. Next, point number 3 is, a lot of times students ask me about the booster vaccine. So patient had taken a pre-exposure prophylaxis. When will we ask that patient to get the booster? So that patient took that 0, 7 and 28 day pre-exposure prophylaxis. The patient is asked to do a follow-up. The follow-up is done using a vaccine neutralizing antibody if it is more than 0.5 international unit per ml. If it is more than 0.5, then you do not need the booster. Pre-exposure prophylaxis booster may be given after 2 to 3 years. So after 2 to 3 years, booster may be given in people who are having high risk occupation, working as forest officers. They are living in the forest or the jungle. They are taking care of the forest. So in those people, it is advised that they should get a vaccine neutralizing antibody done. If it falls below 0.5, you give a booster shot. Otherwise, they can repeat the vaccine anytime after 2 to 3 years. That's just the recommendation for the booster doses. Point number 4, again students ask me that, sir, what to do in case of a home-based dog bite. So in case of all domestic bites, domestic animal bites, if the animal is having a documented anti-rabies vaccine schedule, in those cases, anti-rabies vaccine is not recommended. But again saying, rabies is a fatal disease. ARV, always give ARV in case of doubt. In case of doubt, we always give ARV. It is always advised that even in domestic animals who may have documentation, may not have, you give ARV vaccine. But if the person says that I have a documented vaccine, if the question says that a person already had a dog who was vaccinated and it was documented, what is the next management? Then answer is that in case of documented anti-rabies vaccine to the dog, we do not give the ARV again. But whenever in doubt, we always give it. Another recommendation from the National Rabies Control Program, and of course a very common doubt that the students ask us again, is what about the dog observation beta? Let us say that animal bite is there. We always say it is recommended that the animal, the dog or the cat, whoever the animal was, they should be observed for 10 days. The dog or the animal should be observed for 10 days. Why do you think it was observed for 10 days? Why? Because if the animal was rabid, they will die within 1 to 7 days. So that is the reason we say that the dog should be observed for 10 days. Now let us say, now the guideline comes. Let us say that the person was here. This poor fellow was bitten by a dog and the dog was here. Let's write it down as a dog rather than showing it pictographically to you. Let us say the dog was here and the person was observing the dog. Please note that this guideline is applicable only to the dog and the cat bite. It's not applicable to the monkey or the jackal bite. So in case of a dog or a cat bite and the animal can be observed at home, so you observe the animal. And let us say that this patient had taken a post-exposure prophylaxis, the SN regime. You remember SN regime? SN regime is the intramuscular regime, that is the 5-dose regime and the 5-visit regime. So in this, let us say the patient was taken on day 0, day 3, day 7, day 14 and day 28. That was the regime, and the dog was kept under observation. Now luckily, happy-go-lucky person, this dog actually survived. Dog is alive on day 10. If the dog is alive on day 10th, that is by the end of the 10th day, if the dog is alive, now what are we going to do? Please note that in this case, you are going to omit. That is what the guidelines say, right? So the National Rabies Control Program Guideline 2019, they say that you can omit the day 14, day 14 dose, but you give the day 28. So you can just omit this dose. So what you are actually converting, you are converting a post-exposure prophylaxis into a pre-exposure type of prophylaxis. But of course, this patient has already got a dog bite. So in these cases, the recommendation, if the dog is alive, you can give day 0, day 0, day 3 and day 7 is already given. So you just omit the 14-day dose and you give a 28-day dose. So that is 4 doses. 4 doses will be given to this patient if the dog is alive. So that is what is the newer recommendation under the National Rabies Control Program. So with that, thank you so much for watching this module on rabies and rabies control program.